this acronym dopamine captures the framework that we use in our clinic here in the early stages of treating somebody, with a burgeoning addiction. D stands for data. This is where we ask people to just tell us what are they using, how much, and how often. And this serves two functions. One is that we get the information, but even more importantly, it crystallizes for the individual what their behavior is. Because until we put into words and tell another human being what we're doing, how much and how often, it can often stay in this amorphous state in the dark recesses of our minds. For example, with my own, romance reading novel addiction, I really didn't become aware of it until I was talking with a student and we were in a role play around motivational interviewing, and I was playing the patient, and I sort of said, he said, well, what behavior do you want to change? And I was the patient. I said, I have this reading habit. I didn't elaborate the nature of the reading habit. But as I talked about it with him, the next day, I just couldn't unsee it. Having said it to him, I was like, oh, and even though I was still reading my romance novels, I was now seeing myself reading them in a way that I hadn't before. And often in clinical work, patients will say, well, we'll do something called the timeline follow back method, where instead of just saying, well, how many drinks, did you have this week? I'll say, well, how many drinks did you have yesterday? And how about the day before? And how about the day before? And doing it that way, we're much more likely to get an accurate read. And then often people will say like, oh, wow, it's 20 drinks. Like I hadn't really realized I was drinking 20 drinks in a week. And then we can also use normalized population data and show them where they fit on the pie chart. Because oftentimes heavy drinkers or heavy users will socialize with other heavy users and then tell themselves that that's what everybody does. So then you say to them, well, you're in the 1 percentile of people who drink. Like there are only, the 1% of the population drinks as much as you drink. Plus for alcohol in particular, we have data that tells us what, moderate drinking or what risky drinking looks like. And we know that anybody who's drinking, more than about 7 standard drinks per week or more than 3 on any given day is at increased risk for all-cause morbidity and mortality. So that's useful data to be able to relay to people. The O of the dopamine acronym stands for objectives. And this is where we try to understand why people use. Generally, people are using for one of two reasons: to have fun or to solve a problem. And the problem can range anywhere from boredom, isolation, to depression, anxiety, inattention, you name it. Now, it doesn't mean in this stage of the intervention that we actually agree with the patient that using their drug solves this problem, but it's important for us to understand why, what is their motivation, because even irrational behavior is girded in some type of fundamental rational thinking. So that's very helpful to know why they use. And then the P of the dopamine acronym stands for problems. And this is where we try to get them to reflect on what's not going right about my current consumption. Is it interfering with my physical health, my mental health, my relationships, my work? Sometimes with teenagers, the only thing that they'll identify is that their parents don't like it and they want them to stop. But that's an important, a problem, because any teenager who's willing to come in as a teenager who's got a strong enough relationship with their parents that they want their parents to, approve of their behavior. So then you can work in that space. Well, if this is a problem, maybe we can help you tackle this problem. The A of the dopamine acronym stands for abstinence. And this is really the sort of fundamental core of this early intervention, where we'll ask patients to give up their drug of choice for a month in order to reset reward pathways so that we can see true cause and effect and potentially get them feeling a lot better without having to do anything else. And as I've talked about before, about 80% of our patients who are able to give up their drug of choice feel much, much better having done so. 20% don't. So that's also useful information. Like that tells us, oh, this person has another underlying problem that we have to target. The key piece in, preparing people for this dopamine fast or this abstinence trial is to warn them that they're going to feel worse before they feel better. So initially they're going to go into withdrawal. Universal symptoms of withdrawal from any addictive substance or behavior are anxiety, irritability, insomnia, dysphoria, and craving. If it's a substance like alcohol or opioids or benzos, you're also going to have a profound physiologic withdrawal syndrome. But for cannabis, even if there's not a physical withdrawal, you'll have these psychological symptoms. I have patients with pornography addiction who will endorse not just the psychological symptoms of withdrawal, but also physical symptoms. They'll have actual physical pain after stopping pornography. And I've seen that with other types of behavioral or process addictions as well, social media, video games, gambling. So that, the body is really reeling when we stop our drug because the body had adapted to it and now it has to readapt or unadapt to that phenomenon. So warning people that they're going to feel worse in those first 2 weeks, but if they can just hang in there and get to week 3 and 4, the sun will come out and they'll feel a lot better. The M stands for mindfulness. We often use that word, but maybe don't necessarily know what it means. It's from meditation traditions, Eastern meditation traditions, which has to do with observing our thoughts and our feelings without judgment and without trying to distract ourselves from those thoughts and feelings, just observing it and letting it pass. And of course, this abstinence fast or dopamine fast or abstinence trial is a great opportunity to practice mindfulness because when we can no longer reach for our phone, for example, to distract us from ourselves, we have to sit there and tolerate that moment. And that's very good for the brain because what it does is it essentially, allows those neuroadaptation gremlins to hop off the pain side and for homeostasis to be restored and to get us comfortable sitting with homeostasis and not constantly needing to be, stimulated in some way. The I of the dopamine acronym stands for insight. And this is just, I can't tell you how many times I've seen in my clinical work, people just have that aha moment where they say, oh my goodness, I thought this drug was helping me. And now I can see it was really causing the symptoms in the first place. So that's always really exciting. And then the N stands for next steps. And this is where after the dopamine fast, if patients have been able to do it, and they felt better, then we ask them, well, what do you want to do now? And the majority of people want to go back to using their drug of choice, but they want to use it differently. They want to use less. They want to have a different, healthier kind of relationship. So this is where we talk a lot about self-binding. And self-binding is using literal and metacognitive barriers between ourselves and our drug of choice so that we can press the pause button between desire and consumption. Self-binding can take the form of chronology or time, like telling myself, okay, I'm only going to use on certain days of the week or a certain number of hours a day or between these hours of the day. Or you can use time as a kind of a finish line. Okay, I'm only going to use after I finish X, Y, or Z, or on my birthday, or at this event. So you use kind of time as a construct to limit consumption. Another self-binding strategy is categorical. That's where you tell yourself, okay, I'm going to drink beer, but I'm not going to drink hard liquor. Or I'm going to play this video game, but I'm never going to play League of Legends because once I start that, I can't stop. Or in my case, okay, I'm going to read philosophy and theology at night, but I'm never going to read romance novels or at all or at night or whatever it is that's kind of trips me up. In addition to chronological and categorical, we also have just literal physical barriers where we literally get the drug out of the house. Don't keep alcohol in the house. Don't keep cannabis in the house. Or with our digital devices where we literally lock it up when we're not using it, or power it all the way down, or delete the apps, or turn off notifications. Ways to actually, again, just create these just little bit of barriers which help us slow it down and take that extra moment to ask ourselves, wait a minute, do I really want to be using this drug or am I just kind of reflexively responding to something in my brain? And then armed with a kind of very specific plan about either how to abstain or how to use in moderation, patients go back out and they experiment. And that's the E of the dopamine acronym, experimentation, because, life is one big experiment. So they'll go out and they'll try this and try that. And they come back and they say, well, this worked and that did. And I slipped up here, but I did okay there. And then you kind of continue to modify it.